Hello, my name is Ryan Cates. I am the pharmacist here at Northwestern in our infectious diseases clinic. And today I'm going to be talking about our antiretroviral agents that we can utilize in pregnancy. Our pregnancy related goals of care are both to prevent the mother to child transmission of HIV, as well as to ensure that we're treating mother's HIV disease. Looking at antiretroviral therapy and the components behind it for essentially almost all of our patients, we will be utilizing a combination of antiretrovirals, typically a three-drug combination. The backbone consists of two typically nucleoside reverse transcriptase inhibitors, otherwise known as NRTIs, in combination with either a protease inhibitor or a PI, a non-nucleoside reverse transcriptase inhibitor or an NNRTI, or an integrase strand transfer inhibitor or INSTI. As you'll see as we go throughout this presentation, the INSTI class of medications is our currently most favored class of medications, both for our pregnant and non-pregnant patient populations. Here is a link to the DAHS guidelines for our patients, both who are pregnant and non-pregnant who are infected with HIV. Would highly recommend utilizing this resource as these guidelines do change quite frequently. So what are our actual agents that we have available for these patients? The preferred agents, as we spoke about before, are our two NRTI backbone. You can see here we have a few different options for our NRTI backbone, including a combination of abacavir lamivudine, tenofovir disoproxil and lamivudine, or tenofovir alafenamide and lamivudine, or tenofovir disoproxil with emtricitabine, or tenofovir alafenamide with emtricitabine. In addition to that, we will use another agent with that backbone. Again, we have our protease inhibitors listed here, our azanavir boosted with ritonavir or darunavir boosted with ritonavir. As far as our integrase strand inhibitors, we have dolutegravir or Icentris. There also is a single tablet regimen that we can utilize in these patients that contains our backbone of abacavir and lamivudine in combination with dolutegravir in one single pill that is given once a day. Our next class of medications that we're going to be talking about are our NRTI specifically, or our backbone agents. The first medication within this class is abacavir. This medication can be either given as a 300 milligram twice a day prescription or a 600 milligram once a day prescription with or without food. The biggest thing that I want to point out with this medication is that before patients are given this medication, we should be ensured that we are testing for this HLA-B 5701 antigen. The reason that we test for this is to avoid any type of hypersensitivity reaction. Patients who test positive for HLA-B 5701 should never be started on an abacavir-containing regimen due to the high risk of a hypersensitivity reaction that could even potentially be fatal. Because of this, abacavir should only be started in patients where we have a confirmed negative HLA-B 5701. One benefit of abacavir compared to some of our other medications within the same class is it is not renally adjusted. So this can be a good option for our patients who are living with chronic kidney disease or compromised renal function. You'll see included some brand names below, as well as brand names that do contain the medication. Our next option within our NRTI class is emtricitabine. This is taken 200 milligrams a day without regard to food. There is no dosing adjustment needed in our pregnant patients. The biggest thing to note with this medication is it is active against hepatitis B, so ensuring that our patients who are hepatitis B co-infected have some type of other treatment on board if we are stopping this medication to ensure that there is no flare-up. The brand name for this medication is Emtreva, and you can see the other medications that it is a component of. Another medication within our NRTI list is lamivudine. This medication can be given again either twice daily at a decreased dose of 150 milligrams or all at once at 300 milligrams once daily. Very similar to our emtricitabine, this also can be utilized for patients living with hepatitis B, so ensuring that there is some active hepatitis B treatment on board before we're stopping patients who are stable on lamivudine. The brand name for lamivudine is Epivir. Our next option is a medication known as tenofovir disoproxil fumarate, commonly abbreviated as TDF. It's given 300 milligrams once a day without regards to food. It has been known that there are decreased concentrations in our pregnant patients in our third trimester. However, these levels are adequate enough that there's no dose adjustment needed at this time. Because this medication is highly renally metabolized, it's very important that we're monitoring patients' renal function on this medication. And again, similar to the last two medications that we spoke about, tenofovir also has activity against hepatitis B. So that same hepatitis B warning does carry through with this medication as well. Brand name for this medication is Viriad. Our newer agent of tenofovir is a medication known as tenofovir alafenamide, or TAF. This is one of the larger updates within the guidelines for our pregnant populations, as previously this was not included as recommended agent. Through studies, it has been found that the PK in pregnancy is not significantly altered, and because of this, we can use the traditional dose of 25 milligrams daily without regard to food, without any dose adjustment needed for our pregnant population. We will still have our patients needing to be monitored for their renal function, as this is still extensively metabolized through the kidneys. However, there is decreased kidney function alteration as well as decreased bone mineral density loss. So this is a potential option that would be more beneficial in patients with any compromised kidney function or any history of bone mineral density issues such as osteoporosis or osteopenia. Brand name for this medication is Vemlidy. Our next medication is zidovudine. This will be primarily utilized in our patients who are in the antepartum phase of their delivery, as this medication can be utilized through the intravenous route. For our patients who are pregnant, there's no significant PK alteration, and with that, no dose adjustment needed. For our patients who are receiving this during labor, it will be given as a 2 milligram per kilogram loading dose, then followed by a 1 milligram per kilogram per hour continuous infusion from the beginning of active labor until the delivery of the infant. The most common side effect is anemia. However, for the short amount of time that these patients will be exposed to the medication, it is very unlikely that they will experience any of this anemic side effect. Brand name for this medication is Retrovir. Looking at our NRTIs as a class of medications and grouping some of these adverse effects together, you can see that for a class, nausea and vomiting tend to be the most common side effect. However, that does tend to go away within 2 to 4 weeks and is self-limiting. Larger and more serious but more rare side effect is potential lactic acidosis or hepatic steatosis. This is a very rare side effect, especially with our newer medications that we have available on the market today. However, it is important for us as providers to be monitoring and ensuring we do not see any type of signs or symptoms that would point to these more severe adverse events. We already spoke about need to ensure that we are not stopping an active hepatitis B medication without having another medication covering that hepatitis B treatment. And we spoke about with our zidovudine that we can have anemia that can occur, potentially flu-like symptoms and fatigue. Again, these adverse effects are listed, but for the purpose of utilizing zidovudine intravenously during actual delivery, we should not really see these side effects too commonly. Moving on to our next class of medications are our non-nucleoside reverse transcriptase inhibitors, or our NNRTIs. These medications are as follows. The first medication I will speak about is efavirenz. This is no longer recommended for patients. However, you will see patients who are historically on this medication coming into clinic, so I thought it was worth mentioning. It can be given once daily before bedtime on an empty stomach. It is noted that in our patients who are pregnant, that the concentration did decrease during the third trimester. However, the third trimester patients were still obtaining an appropriate level of drug. No dose change is thus indicated, and the brand name of this medication is Sestiva. Again, not a medication that is recommended or commonly used, however, wanted to include for completeness. Looking at our NNRTIs, the most common adverse effect is rash. This can range from a transient mild rash all the way to a more intense Stevens-Johnson syndrome-like reaction. Efavirenz is often associated with things such as flu-like symptoms, as well as CNS side effects, including very vivid dreams, whether that be a nightmare, neutral dream, good dream, or potentially increasing psychosis, depression, anxiety. Our next class of medications are our protease inhibitors, or our PIs. Atazanavir is one medication we can utilize in our pregnant population. This medication will need to be boosted or pharmacokinetically enhanced with ritonavir. So it is given as 300 milligrams plus 100 milligrams once daily with food, typically in our non pregnant populations. For our pregnant patients, we do see decreased concentrations during pregnancy, which can be even decreased further when given with tenofovir or potentially an H2 receptor antagonist such as famotidine. It's important to note that azanavir should always be utilized with ritonavir during pregnancy and is not recommended for treatment experienced patients who are taking tenofovir with an H2 antagonist. There's low placental transfer to fetus. However, it is important to note that hyperbilirubinemia is relatively common and can occur in neonates as well. And again, we should be avoiding any of our acid suppressing agents. This includes our proton pump inhibitors. These are agents such as omeprazole and other PPIs. Looking at atazanavir specifically in our pregnant population, during patients' second and third trimester, the dose of atazanavir should increase from 300 milligrams to 400 milligrams. The booster dose of the 100 milligrams with ritonavir will stay the same, and this is to ensure that we are having adequate plasma concentrations that are equivalent to our non-pregnant adults. Again, please keep in mind the importance of avoiding our acid suppressing agents, as we do require an acidic environment in the stomach to have full absorption. One medication that is available but not recommended for our patients is atazanavir combined with a different pharmacokinetic enhancing agent known as cobicistat. It is thought that cobicistat is not effective enough in our pregnant populations to produce the amount of concentrations needed for true viral suppression, so any regimen containing cobicistat should not be utilized in our pregnant population. Our second medication that is a protease inhibitor that we can utilize in our pregnant population is darunavir. Darunavir in pregnancy is given 600 milligrams plus ritonavir 100 milligrams, both twice daily with food. It is given this way as there's decreased exposure in pregnancy, and again, we must be ensuring that we are boosting it with our ritonavir. There is low placental transfer to the fetus. The brand name for this medication is Persista. Looking at our dosing in pregnancy, we will utilize 800 milligrams taken with ritonavir 100 milligrams daily in certain patients who are already stable on this dose. However, for the majority of patients, we should be changing to 600 milligrams with 100 milligrams of ritonavir twice daily. Again, the preferred dosing is at 600 milligrams with 100 milligrams twice daily of darunavir and ritonavir. Again, similarly to our other medication with our protease inhibitor attached to our cobicistat, this should not be utilized in our pregnant population. So our darunavir with cobicistat or Prescobix should not be utilized in this population. Looking at other factors to think about when prescribing a PI for a patient, the largest factor to consider is the fact that our protease inhibitors have a very high propensity for interacting with other medications due to their CYP3A4 inhibition. We are also utilizing a pharmacokinetic enhancer, which will enhance not only our medications that we are aiming them to enhance, but other medications that go through the CYP3A4 pathway. These include common medications such as antifungals or anti lipid reducing medications. Looking at adverse effects that can occur with our protease inhibitor class of medications, we spoke before about our hyperbilirubinemia associated with anazanavir. With darunavir, there is some thought that due to its chemical structure, that patients who have a sensitivity or an allergy to sulfa medications should not be started on darunavir. Personally and professionally speaking, I have yet to see this being a large crossover, so I would not have this be a preclusion from starting somebody on a darunavir-based regimen if they do have this sulfa allergy. However, it is important to note that darunavir can cause a rash, and to ensure that if rash does develop, that we are stopping it in these patients on darunavir. Looking at a class adverse effects with these medications, the most common class side effect is metabolic complications. These can include things such as dyslipidemia, fat maldistribution, potentially insulin resistance. It also can cause nausea, vomiting, and diarrhea. The important thing to note with this is our GI side effects are not self-limiting. These can occur for patients throughout the entirety of their course of treatment. So if a patient is reporting extreme GI distress with these medications, it would be worth switching patients off as they most often will not improve. Also, as we spoke about before, you will have that CYP inhibition with increased drug-drug interactions. Our final class of medications we'll be talking about today are our integrase strand transfer inhibitors, or our INSTIs. Our first medication is dolutegravir. For our patients who are naive or who have no resistance to dolutegravir, we'll be given it as a 50 milligram once daily dose without regard to food. In patients who have any INSTI experience or resistance, we will give 50 milligrams twice daily without regard to food. There is limited data in human pregnancy. However, the data that we do have suggests that 50 milligrams daily is an appropriate dose for our pregnant patients. Raltegravir is another option that we have in this medication class. This is given twice daily without regards to food. In our pregnant populations, we do see a decreased level of this drug within the third trimester, but again, similarly to most of our other agents, the decrease is not enough to warrant an increase in dosing. Of note, there are case reports of increased liver transaminases used with this medication in late pregnancy. Most patients will prefer to utilize a medication such as dolutegravir, as is given only once a day compared to our raltegravir, which is given twice a day. Looking at our class adverse effects with these medications, the most common are fatigue, CPK elevation, and weight gain. The fatigue is a transient side effect that, again, should go away in approximately 2 to 4 weeks. CPK elevations, while rare, can occur more so with our Icentris medication. So important that patients are reporting any side effects such as muscle pain, things of that nature. The weight gain is a newer idea within the field of HIV pharmacotherapy, where we are noticing that patients, specifically on integrase inhibitors, are noting weight gain throughout the course of their treatment. If patients are noting this weight gain and is an excessive amount of weight, this could be a reason to stop the medication and consider switching to an alternative agent. Looking at our neonatal considerations for our medications, we have our neonatal antiretroviral management. It is broken down based on whether patients are low risk, high risk, or the newborn is born with HIV. For our low risk patient, this includes patients or mothers who have been receiving active retroviral therapy during their pregnancy with an undetectable viral load near delivery, and there's been no concerns related to adherence. Patients with this category will have their children or infants receiving zidovudine for 4 weeks. For our patients who fall into the high risk category, these would include patients who did not receive any type of antiretroviral therapy, who only received antiretroviral therapy intrapartum. For patients or mothers who received intrapartum drugs but did not have viral suppression near the delivery, or for patients who are actively breastfeeding with acute HIV infection. Looking here at our neonatal management for this group of patients, we can utilize a combination of zidovudine, lamivudine, and nevirapine therapy, or zidovudine, lamivudine, and raltegravir therapy. Of note, this is going to be 2 weeks longer at a 6 weeks of therapy treatment. Finally, we have our newborns who have tested positive for HIV, and they will be given a 3-drug treatment regimen using appropriate treatment doses. The ARV registry reporting collects observational as well as non-experimental data on antiretroviral drugs used for the purpose of determining the potential teratogenicity of these drugs. And you can see the information listed above. I also want to speak briefly on medication access issues, as while we have some great drugs available for patients, if they're unable to access the medication, it is a moot point. The first thing I would like to talk about is prior authorizations. This is the process in which insurance requires additional information or additional work through to get these medications for patients. The process is that the physician will send in the prescription. The pharmacy will attempt to run this prescription or adjudicate this prescription through patient's insurance. If it does reject, if they are informed that a prior authorization is needed, they will then contact our office and we will complete the paperwork requesting this medication to be a covered benefit through the patient's insurance plan. In general, most of the time that we submit these requests, we should have a response back within 1 to 3 business days. Um, and at this point in time, the medication will either be approved and patient will be able to receive it, or it will be denied, and we will either consider switching medications or pursuing an appeal. Of note, appeals can take up to 30 business days, so it sometimes may not be the most appropriate choice in our patients, or we may not be able to obtain that medication right away. What I would recommend is if there's ever any questions about the prior authorization process or if medications require prior authorization, please do not hesitate to reach out to the pharmacy team located in the ID clinic. We are located in the pharmacy office, which is right down the hall from the physician workroom and nursing workroom. For our patients who do have insurance coverage, however, their insurance is leaving them with a high copayment, we can utilize something known as a copayment card. These cards are produced by the manufacturer of the drugs and often can reduce the cost of medications for our patients down to $0 a month. Again, for any copayment cards assistance that is needed, please reach out to the pharmacy team and we are happy to help. The one thing I do want to notate on here, however, is that patients who have any type of government provided insurance, whether this be Medicaid or Medicare, they are unable to utilize copayment card assistance. If there are these patients who are on this government funded insurance who are still being informed of high copayments for their medications, we do have other options we can utilize. So again, please reach out to the pharmacy team and we can discuss that in more detail on a patient to patient basis. Regarding Medicaid, these patients have a large number of restrictions on what medications are covered, as well as the quantity covered per month. The two medications I want to specifically notate here are our antiemetic medications, are ondansetron and diclegis. Both of these medications are not covered per our patients who are on Medicaid. For our patients who are on Medicaid, diclegis will need to be broken up into its separate components for patients to be able to receive this. Another program that I want to speak about today is the AIDS Drug Assistance Program, commonly known as ADAP. This program is a program that allows patients to access free drugs in 6-month rolling periods. Prescriptions need to be sent either to CVS Specialty in Monroeville or the Walgreens here at Northwestern. Patients can then have the prescription mailed to their home or mailed to a local Walgreens for pickup. I apologize for the CVS in here, but that will be a local Walgreens for pickup. This provides patients with a 30-day prescription and 5 refills, and patients are able to get at least 4 of their medications associated with their diagnosis for free. So we need any type of opportunistic infection medication paid for as well. These also will be covered under the ADAP formulary. For ADAP, I would recommend reaching out to our social work team as they are highly experienced in getting patients enrolled in this process. I wanted to note as well the specialty pharmacy that we have here on campus. They are located on the 5th floor of our Arcus Pavilion. This specialty pharmacy is directly associated with Northwestern, meaning that all of the pharmacists and technicians within the pharmacy are able to utilize the Epic system to look at both chart information as well as insurance information for patients. I highly recommend for new start medications that medications are sent to the specialty pharmacy due to their expertise and ability to get medication out to patient quickly. We spoke already about some adherence issues or some access issues, I should say. However, I did want to bring this up as well, that we can have the expectation of what patients might be bringing or seeing versus what the actual reality of the situation is. A large amount of pill boxes. If there are ever any issues with medication reconciliation, again, please do not hesitate to reach out to the pharmacy team, and we will do what we can to reconcile these medications and ensure patients have an appropriate plan to take their medications moving forward. This includes things such as creating adherence aids, so something such as a medication schedule as seen here. We have both pill boxes in the clinic, individual keychain pill containers, as well as pill assistance, or I should say swallowing assistance tools such as this pill cup. Located within the pharmacy office, we have tablet examples of all of the medications available on the market now. This can be a really useful tool to utilize for patients who are concerned about the size of a medication or any appearance concerns or questions about medications. Included here, we have some helpful HIV resources. As we spoke about, there is the Antiretroviral Pregnancy Registry listed here, the guidelines for our patients living with HIV. And then finally, I find a very useful website here, this HIVdruginteractions.org. Not only will provide you with what interactions are available or currently occurring with the medications utilized in a patient, but also will provide dosing adjustments and evidence behind those recommendations. To contact the pharmacist from the ID clinic, there are a few different routes you can take. The email is the idcenterrph@nm.org. Our direct line is 68065. We also are logged into the pager from 8 a.m. to 4:30 p.m. Monday through Friday with the pager number of 17289, or you can search for Pharmacist ID Clinic. And finally, we do have our own Epic pool listed here with the pool number of 12611. If there are any questions, please do not hesitate to reach out again with this contact information provided. And I hope you all have a good rest of your day. Thank you.